Dr. Nicola kbuget is a professor of hematology in Frankfurt University, Germany. She is a leading investigator in several important papers, including blinatumomab. She's also the first author of several hundreds of papers. Without any further delay, Dr. Nicola, the floor is yours.
Yeah, thank you very much for the kind invitation. It's a real honor to participate in this session. And also congratulations to all your activities in Saudi Arabia regarding the management of acute lymphoblastic leukemia and other hematologic diseases. It's my pleasure today to speak specifically about the management of MRD positive ALL. And I do this mainly in my role also as a leader of the German multi-center study group for adult ALL, in which more than 150 hospitals participate, and therefore I know the networking issues very well. These are my disclosures, and I would like to start with a few definitions about MRD. So if we have blasts above 5%, clearly we have hematologically or cytologic relapse or failure of the disease. Between 5% and 0.01% is usually the level where we have quantifiable MRD. So most methods for MRD detection have a sensitivity of about 0.01%. Now below this level, with some methods, we have the option to detect also MRD on a low level, sometimes also not quantifiable MRD. So this is a kind of intermediate MRD situation. And then we have a MRD negative status, which actually means non-detectable MRD. And we know that the relapse risk is very high for patients who remain after the standard therapy MRD positive above 0.01%. And we know that patients who are MRD negative have usually a very good prognosis in the low relapse risk. For the intermediate patients, we don't know the risks very clearly, and I will come back to this issue a little bit later. Now, I think everybody knows that the MRD persistence is very strongly correlated with outcome in pediatric ALL and in adult ALL on the right side. This is the strongest prognostic factor for both diseases, and patients who remain MRD positive nearly all relapse despite continuous treatment, and their overall survival is also very poor, as shown here in this large meta-analysis. It has also been shown by other meta-analysis, here a more recent one by Renato Bazan, showing that patients with persistent MRD have always a strong prognostic impact on the overall survival. So based on these data, clearly we need to analyze MRD in all ALL patients. This is one of the most important diagnostic procedures, and we have different techniques available. I don't want to go into detail for that today. Maybe we come to this in the discussion, but it's very important that we need to standardize these methods. We have to take the shortcomings of different methods into account. For example, maybe a lower sensitivity with flow cytometry. This is one of the issues. Or, for example, the longer time to receive results with a PCR-based method. And what is also very important is the reporting of the results. An MRD report should always include the level of MRD and also the sensitivity, particularly when the MRD result is negative. And we have very clear definitions now implemented in the German ALL group for the failure and the relapse on the molecular level, on the MRD level. So we speak about a molecular failure if the MRD is above 0.01%. And we speak about molecular relapse if a patient is first in molecular CR and then comes back with MRD positive status. And these definitions are used in the trial and also used for decision-making on treatment modifications. And therefore, the clear definition is very important. Now, another issue is which time point is most relevant for treatment decisions. And this depends certainly on the different protocols. What I can say from our experience is that when we have a very early time point, and this is, for example, day 11, this is only after vincristine, dexamethasone, and 2 days of daunorubicin in our protocol. If a patient is MRD negative very early, as shown here, the prognosis is excellent. However, only a very low number of patients, less than 10%, come into this very favorable subgroups. On the other hand, at later time points, this is here week 16, which is after induction, 2 phases, and the consolidation treatment. If a patient then remains MRD positive, the outcome is very poor. So early negative is excellent prognosis with continued treatment, and late positive is poor prognosis despite continued treatment. So the optimal time point for decision making depends on the planned consequences. Here you can consider, for example, treatment reductions in the positive patients, treatment in
Dr. Nicola, you are muted.
Okay, so level of MRD is important as well. And I show you here the European meta-analysis, which indicates the correlation of MRD level, better prognosis with lower MRD levels compared to the poorest prognosis in patients with high MRD levels. And on the right side, you see here the differentiation for patients with MRD below or above 10 to the minus 3. So clearly, the higher the MRD level, the shorter is the interval to the forthcoming hematologic relapse. But what about the intermediate MRD levels? We have analyzed this in our data set, and as you can see, about 60% of the patients after induction therapy have a molecular CR, and the overall survival of these patients is excellent. There are a few patients who are MRD negative, but the sensitivity is not sufficient. Again, these patients have an excellent prognosis in terms of survival. Then we have the molecular failure patients, 18% of the total population, and their overall survival is very poor, mostly due to relapses. But patients who are low positive, so below 10 to the minus 4, or non-quantifiable, they have an intermediate prognosis. So the overall survival is 68%, remission duration 76%. So I think it's very important to know the exact MRD level, and not all types of MRD positivity mean the same for the prognosis. So this brings me to the treatment options. And first of all, in patients with an excellent prognosis, I've shown you those patients who already are in molecular CR after the first days of induction therapy. Here we could consider a de-escalation of treatment, which has been tried in pediatric ALL in some trials, and I think we must be very careful with that. On the other hand, the biggest problem which we have in adult ALL is actually the group of patients with poor MRD responders. And what was tried in this patient population was to intensify standard treatment. And I show you here some data which we have generated in our German ALL group. If patients with molecular failure were treated with high-dose methotrexate asparaginase, and this indicates a 24% additional molecular remissions. Also, other chemotherapy cycles indicate very few additional molecular remissions. So we can understand from these data that the use of further chemotherapy does not help in these patients usually, because they are somewhat chemotherapy refractory. So the next approach, which was considered in these patients, to offer them immediately a stem cell transplantation as the most intensive treatment which we have available. And I also don't want to show many data on this, but only a summary table that patients with a high MRD level before the stem cell transplantation have a poorer outcome after the transplantation. So transplantation is certainly a good idea for these MRD positive patients, but not optimal if it's done immediately in the high MRD level situation. And this brings us to the idea to use alternative compounds in these patients with different mechanisms. Yeah.
We lost your slides. I don't know if you can reshare.
Oh, sorry, I don't know.
Just now.
Is it available now?
Not yet.
Okay.
Okay, it's loading now.
I don't know why this happens, but I'm sorry.
Sorry about that. Oh, sorry.
So, do you see it now?
It's loading, so I think it's coming.
Mm-hmm. Do you see it?
Not yet.
No, I don't know what else I can do. Because
just a moment.
I see it.
Professor, I can see your slide. All right, please. I can see your slide. Put in slide mode. And now it's working for my side.
You can see it? Okay. Okay.
Okay.
I can see it too.
Yeah,
Okay.
you can go ahead.
Good, very well. So, so as I said, the situation in the MRD positive ALL, which are chemotherapy resistant, brings us to the idea to use compounds with different mechanisms of action to reduce the MRD load before the stem cell transplantation, and also to maintain the remission in patients who are not candidates for a transplant. And in ALL, we have, beside pH positive ALL, very little options for molecular targeted therapies, and therefore the immunotherapies are very important. Which are rituximab, part of this, in many protocols already part of the standard of care, inotuzumab, a CD22 antibody, blinatumomab, and also the CAR T cells. Now, blinatumomab was used in different settings in the relapsed refractory setting, and this is a summary of the data here, showing that the CR rate in the full relapse is always around 40%, 43%, and the median overall survival in the situation is rather poor. It's better than chemotherapy, but we cannot be satisfied with this outcome. And therefore, the consideration came up to use a compound at lower MRD levels in MRD positive patients and not in the full relapse. And we did a small pilot trial in Germany with blinatumomab in MRD positive ALL, showing in 20 patients a quite favorable overall relapse-free survival, 80% response after only one cycle, and some very few patients remained long-term remission without further therapy. And there's also a long-term follow-up of this trial showing that the number of patients remain in long-term remission. All the long-term survivors had achieved MRD negative remission after the treatment of blinatumomab. Some of them were transplanted, a few were not transplanted. And based on these very, very promising data, we decided to perform a larger international trial, which was an Amgen trial, in MRD positive ALL above 10 to the minus 3, the MRD level, so a rather high MRD level. Patients were included in first remission MRD positive, but also in later remission. 35% were MRD positive after a prior relapse. Overall, 100 patients were included. And as in the pilot trial, 78% of the patients achieved a molecular remission after one cycle of blinatumomab. And as you can see on the right side, there were no entry criteria like age or remission status influencing the remission rate. So in all subgroups, the response rates were very good. Importantly, in the MRD setting, we don't do a dose step. So in MRD, in the relapsed refractory setting, blinatumomab has a dose step after 1 week. In the MRD setting, we start with a high dose already at the beginning. The overall survival on long-term follow-up is shown here, 36 months median, which is very favorable, particularly if you compare it with the relapsed refractory setting. Patients achieving a complete MRD response have an excellent outcome compared to those who don't have a complete MRD response. So it's a clear advantage for the patients responding, and this is already after one cycle. Comparing patients treated in CR1 and in CR2, you can see that the patients in CR1 have a better outcome, but also the patient in CR2 who remain MRD positive after a salvage treatment can benefit from the additional use of blinatumomab. Now, one of the most important questions which we try to address in discussions about this trial is the question whether we need a transplant in patients who are treated with blinatumomab in the MRD setting and achieve a response. And these are the blue curves here. On the left side, you can see the patients who have been transplanted after achieving a molecular remission. On the right side, the patients who are not transplanted. And on first sight, both curves don't look much different. But there are differences behind that. And the most important difference is that these are very, very few patients who were not transplanted. Overall, 70% of the patients had received a stem cell transplantation. And there are more differences. For the transplanted patients, we see that it's a quite high median age of 42 years. Most of the transplantations were unrelated. 34% were mismatched transplantations, and despite the higher age, most patients had a myeloablative conditioning regimen. And from these characteristics, we can anticipate that there's a higher risk of transplant-related mortality in this patient population. And this actually also happened. You can see here the outcome in green for the patients who had received a stem cell transplantation after blinatumomab, and in orange, those were not transplanted. And the major difference is here that with transplantation, more patients stayed in continuous complete remission. On the other hand, most patients who were not transplanted relapsed. The problem in the transplanted patients is the relatively high transplant-related mortality, which was here 36%. And I have mentioned the potential reasons for this problem. Some of the patients who did not receive a transplant received a transplant after relapse. So even the patients here considered as no transplant had a transplant in a later time point in some of the cases. So overall, we have the dilemma. The transplanted patients have a high mortality and probably suboptimal transplant procedures, as shown before. The non-transplanted patients have a higher relapse risk, and because they had no standardized follow-up treatment. A solution can be different. So we should avoid probably high-risk transplant procedures in patients who respond to blinatumomab and evaluate dose-reduced conditioning in these patients. And in the non-transplantable patients, we should do the MRD follow-up and also a consolidation and maintenance therapy. So overall, blinatumomab in MRD-positive ALL has a high response rate. There is no dose step, which can be a reason for the good outcome also, the good tolerability, a benefit for the responders, and much better results compared to the relapsed refractory setting. And we also compared in a historical comparator analysis with standard care therapy, blinatumomab, and this also confirms the advantage of this treatment approach, which we currently also use in our first-line treatment. Now the question is whether this is already standard of care, and I think this is a recommendation from the North American expert recommending in MRD-positive patients with B precursor ALL 2 to 4 cycles blinatumomab and then an allogeneic transplant. Maybe we can a little bit more differentiate the situation sorry, I go back one slide. And consider here for MRD positivity, the MRD level, because not all MRD levels lead to a stem cell transplantation. I have shown you before that patients with low MRD have a intermediate prognosis. So this is something we should consider. And so in our group, we do the induction and consolidation, and in standard risk patients, according to the criteria like white blood cell count or molecular criteria, we continue the standard treatment if the patients are MRD negative, and if they are positive above 10 to the -4, we give blinatumomab and then a transplant. If they are low positive, we try a targeted therapy, but then continue with standard treatment. And there's a similar approach in the high-risk ALL. Now, we have continued to analyze blinatumomab in the MRD setting, and in our trial, we have, in the meantime, 65 additional patients. The overall molecular response rate is 80%, so as in the BLAST trial and also in the pilot trial, the response rates are very good. The overall survival is also about 70% at 3 years, so very favorable. I would like to mention one point which can be important also for the further use of blinatumomab. And what we have seen here on the right side is that patients who do not achieve a complete MRD response after blinatumomab, so these are the green patients, molecular NA means low positive, they apparently have a trend to a little bit poorer prognosis, and therefore we may consider in these patients who remain somewhat MRD positive in after blinatumomab therapy additional treatment approaches. Also in the pediatric setting, it has been demonstrated in a real-world data collection that patients with MRD setting, so blast count below 5%, have an excellent prognosis and response rates, and compared to those patients who have a higher blast count, and which means a full relapse. So the best setting to use blinatumomab is certainly the MRD setting. And this brings me to another pediatric trial, which has been discussed a lot in the past weeks and months with blinatumomab in the high-risk relapse. Hello? Do you hear me?
Yes, we hear you.
Okay. And in this trial, the patients with high-risk relapse had induction, consolidation, 2 cycles, and then they were randomized between blinatumomab and another chemotherapy cycle. So actually, this is an MRD trial where blinatumomab is used in the MRD setting. And as shown at the ASH meeting by Franco Locatelli, all of the patients were actually in the MRD situation when they received blinatumomab. And this trial showed a significant advantage in all endpoints for the use of blinatumomab compared to this additional high-dose chemotherapy cycle. So again, another confirmation that at least one cycle after prior chemotherapy can be replaced by blinatumomab with a big success also in terms of toxicity. Also, the trial by Robin Foer and colleagues in Ph-positive ALL, published in the New England Journal of Medicine, is an MRD trial. So here the patients received steroids and dasatinib, and then they received 3 to 5 cycles of blinatumomab together with dasatinib. All patients, 98% were in CR at this time point, only a few patients, 10% in molecular CR. And therefore, this is an MRD trial in Ph-positive ALL, and with additional blinatumomab cycles, the percentage of molecular responses increased by each cycle, although not all patients achieved a molecular response. Overall survival, it looks quite promising, but I think that a further follow-up of this trial is required because in Ph-positive ALL, we really need long-term survival data. Now, what about the CAR T cells? Also here, we have often the situation that the patients are included in the trials in the full relapse, but in the time point when the CAR T cells are given, they have only MRD. So this is shown here in this trial by Park and colleagues that nearly half of the patients were only MRD positive at the time point of infusion, and half of the patients had still a relapse situation. And you can see from the curves here that in the MRD setting, the outcome data were much better than in the patients with the higher disease burden, meaning a full relapse. Also, the real-world data of the CAR T-cell consortium show a similar picture. The overall survival and the event-free survival is much better with lower disease burden compared to high disease burden, again, defined as the MRD setting compared to full relapse. So also for the CAR T-cell, the MRD setting appears to be a favorable treatment situation. And this brings me to summarize that a standardized MRD assessment and reporting is essential. The best time point is after an adequate standard therapy. The MRD level is essential for treatment decisions. The targeted therapies are most promising because the patients are chemotherapy resistant. For the moment, we be careful with treatment reductions for patients with good MRD response. And there are a number of open questions, for example, whether we need a stem cell transplantation after an immunotherapy in MRD positive patients. And we also do not much about the prognostic impact of MRD after a salvage treatment. So thank you very much for your attention, and I hope that the technical problems were not too disturbing.
Thank you, Prof. kbuget. Outstanding talk.